Folks, we have possibly one of the most brilliant women in the room on today, and I am not exaggerating that by any stretch of the means. Backstory, I met today's guest, Dr. Ivonne Maldonado. Please tell me I got it correct.
That was great.
You should have seen, I so want to make sure I do it correct to honor you. So pressure on Shell.
Hey, everybody. Well,
Y'all, she is legit so brilliant. And I think the first time that we met in person was at the bottom of the steps of the escalator at Asha 3 years ago. I think it was 3 years ago. And it was just like this incredibly joyful moment. And y'all, she has a master's of legal studies from Arizona State University's Sandra Day O'Connor College of Law. She has her Ph.D. She had like all of the certs and the trainings and is such a advocate for our profession and for those who need to be seen and heard in our profession and those that we serve in our profession, which is what we're talking about today, social determinants of health and how they impact pediatric feeding and swallowing disorders, because they do. Oh, Lord Almighty, they do. Everything from advocacy and knowledge about what a PFD is to actually getting the patients and the clients into us to how do we advocate for a professional practice with other professional partners, as well as access to feeding tubes. The list goes on. So this is a talk that I'm really, really excited about. And please know, I even made sure I got flowers at the grocery store to so I was celebrating you by flowers.
there, because in my office there's no sunlight, but at least I have the light here.
I thank you for coming on.
Hi, Michelle. Thank you so much for having me. I just still remember the first time we met where I was like, maybe I'm going to be like, just too much, but it's like I follow you and I love you and I haven't met you, but I wanted to just say hi. And it just grew from there. And I just love how we have been able to just talk and collaborate and everything in the world. So, you shared a lot about me. I'm going to just add a little bit more. So I am from Puerto Rico, the archipelago, or some people call it the island of Puerto Rico. I've been there all my life. I became an SLP after doing biology. My dad is the doctor. I love him so much, and he wanted me to be a doctor, and I worked so hard into trying to be that. And I also wanted to be like a preschool teacher. So in that sort of point in my undergrad, I met an SLP who just told me, you can have a little bit of the best of both worlds and your interest with becoming an SLP, but you just help, she just taught me all of this about the beautiful things we do as speech language pathologists and communication and quality of life. That's the route I ended up taking. And then I moved to the mainland in Georgia for like a year and a half to do ACF, where it was like feeding in a pediatric clinic and then in the SNF. And then I came to Arizona, which I thought at the end of the world because it's like Puerto Rico to Arizona, like the desert. And you real view Arizona. It doesn't feel like those movies, but it's really fun to see the roadrunner running around and you imagine the cartoons from when you were young. And here I was working in the pediatric battered children's hospital, supporting, our infants. And I am right now at Slow University in Arizona, a new program. We're very excited about it. And it just kept growing. So I am crazy. Just like Michelle mentioned, I recently did a master's in legal science. I just feel so passionate about equity, advocacy, and I just wanted to just understand the law to see what's best, what more can I do for my clients that I have, right, and seeing here, but are immigrants that speak other languages. Like, how can I just, without overstepping, help them understand more of what they can be?
Yeah. And folks, I don't know, we never know who's listening. If you're an SLPA or if you're an SLP, or say you're an undergrad and you're just looking into like our field. I had the pleasure of working with one of your colleagues, Dr. Tiffany Hines, back at Francis Marion University. And the team and the kindness, compassion, and understanding that they have for creating a robust cohort with emphasis on really immersive clinical practicums is phenomenal out there. So if you're looking for a really good program, and you can handle the heat, becomes
What could be just one year in Arizona, one of the big amazing things, where it's not this, but it's at your second year, we find your rotations in any part of the US that you want to go tackle. So it's just a great thing. We don't say that the word diversity is such a thing right now, but technically, like, we're looking for that, for increasing diversity in our field, including people who are passionate with becoming culturally responsive clinicians, where we hear you, we listen to you, and just reach out and hear us. But our faculty is so diverse too. It's not like we're just preaching to the choir, like we are ourselves. It's quite interesting to see how we all like just talk to each other and love each other and just imagine ourselves in a meeting in a faculty meeting. It's crazy but amazing. Like, it's just but there's so about so many things.
so yes, so there's that. So be sure to take a peek. But and Waffles is excitedly sitting beside us, chewing on a brand new bone because so far this week in Waffles update, she has managed to eat a laptop charger, a cell phone charger, and yesterday she puked up a sock. So that was exciting to pull a sock out of her throat and realize what in her clothes. Yeah. So it's like having a toddler again. It for the home front update, but take us from the beginning. Like, you got into the world of pediatric feeding disorder during your CF, which is like this coveted goal for so many clinicians and future clinicians. How did you make social determinants of health? Where did you find that intersection with PFD? What describe that for us?
So because we don't know this, I want to talk a little bit about what social determinants of health are. If that's so, when we talk about social determinants of health, we're talking about those non-medical barriers that can impact or affect what we see as our health outcomes. So it's not necessarily in in any field, like, when you're talking to your doctor and everything. So we see your employment, your income, let's say you're in literacy, you're in language, like, are you, when we talk about those clients, or questions as an SLP, what type of education did you get before we ask them how the question. So they have access to insurance, where they travel to come into our, the transportation to our clinic and getting our service, those one, just that social aspect of it and the cultural aspect of it that can change that. So if I see or think about how it can intersect with pediatric eating disorders, if we think about pediatric eating disorders, we're also considering all the four domains. And you have that medical domain, we have the nutritional domain, the eating, the psychosocial. So they just overlap in so many ways. And to be more specific, it could be that we don't know if a caregiver can afford any specialized treatment, whether it's ongoing therapy, whether it's getting approval or even formula or feeding tubes. We don't know if they understand very well what they're talking to them. Like, I tell my students that when you're giving a diagnosis, it could be the best thing in their life, or it could be the worst thing in their life. But back in a way, but they have been looking so long for answers that you probably give it to them, or the worst, because they finally know, and they knew, but they're still waiting for that. So thinking of how, or considering how they are understanding what you're talking during your session, whether it's your education, your assessment, your screening, or your treatments, where it's important to know how well they're going to follow through later on with their strategies for bookies. We recommend all the recommendations to the printed, know quality in another language. Like, another intersection that I see is that PFD is so broad, it cannot really work with one profession. They work in multidisciplinary things. We have so many people working together that healthcare access may be limited. So we need to understand who can they see, how they see, who can collaborate in that treatment of PFD. So it's not like they just came to us and that's it. We need to understand and see the person as the whole and not just treat one thing. So So it does, the social determinants of health does influence us. If we consider the neighborhood for it, all of the social determinants of health, we need to see, and I like giving this example, which is the housing. When I moved to Georgia, in the neighborhood I lived in, I went through Google Maps in the 3D moment. I couldn't afford just drive flying to Georgia, just seeing where I wanted to live. So I found this apartment and I'm like, oh, this looks good, but I never saw the surroundings. I was completely safe, but it was a low SES area. And what happened is that in the houses, you saw like 7 cars parked in. And when I started to meet the clientele that I was seeing, because I was one of the few, we were like foreign folk Spanish, we started seeing the clientele and we started getting to know them. The whole family lived in the house because they couldn't afford housing. So are they inside the house? Do they like what state space to be able to stay comfortable right during meal times? Are they maybe in a neighborhood that's far from a supermarket that can provide what we're recommending as SLP? And considering that crowding environment also into the social, right? If we're talking about, I can talk about my family or any family, like, oh, Mija, you have to eat a little bit more because you need to get bigger, or that peer or family support, but also the pressure and what are the really relevant resources that we have. So all of those things are when you combine, and it could keep growing, like the social determinants of health and the PFD. But a big thing that also goes into it is that caregiver world.
So much yes.
Okay.
Also, all I can hear is my mother-in-law when Bear was like 5 to 8. She was like, he needs to eat more. He needs to eat more. And I'm like, would you leave him alone? He eats everything. He just has great metabolism. And so love that you gave that tie in the family piece.
You you give them more food, and then they're like, oh, you're a little, a little chunky, a little big, you got bigger, so you have to eat less now. And it's like, what are we promoting? Like, we're constant caregiver worry is a big thing because it's the worry because of those factors.
Well, and okay, so this to me, the social determinants of health beautifully interlays into the psychosocial domain of PFD. So when we're looking at the 4 domains, we have our medical, our feeding skill, our nutrition, and our psychosocial. Well, technically, it hits all of it.
It's like you can probably can't like point them out. It's like they same as when you're treating PFD. There's always one or two that go together. All of right. It's very hard to separate them.
Yes. So I'm going to put this in the universe. I think you and I should make a graphic. I think you and I should make a social determinants of health graphic and overlay it with PFD and give specific examples because that doesn't exist. And I could use that tool for my graduate students because shout out to North Carolina Central University. Whoop, whoop. But like what I find is that folks want to jump straight to the treatment and the intervention. And to quote Dr. Amy Delaney, who runs Marquette's neurodevelopmental peds feeding lab, she always talks about how treatment is sexy. People want to skip over it's hard to think of anything that I do as sexy because like I crawl on the floor all day long and have way too much stock in leggings. But she's right. But the eval and that first or second session after the eval is where you have this opportunity, if you truly engage in caregiver routines-based intervention, to help pull together, or maybe I should say, unlayer the social determinants of health and how they impact. Yes. So
Yeah, big thing is that there's a lot of barriers in the field. I'm not gonna lie. There's lack of time. There's, a lot of constraints of 45 minutes, sometimes 20 hours, whether we have an hour, whether we have more or less. But I talk to my students and I tell the rapport story so important. Like, you cannot assume that you're seeing a client and we're gonna come back. It all changes with your interaction. You need to create a safe space for them. You need to create a safe space for the parents, the caregivers, the family members. So in that process of the rapport, doing And maybe I'm talking to a little bit of what we may fall in later, but it's that ethnographic interview component that we also train our school here into. It's like, oh, do you have any medical, like, not only that they would take questions, it's more of just tell me more about what your routine is. And then from me, you get that it's not like it's not like, I feel like what you mentioned, what are the difficulties they're having, you're written starting negative. I don't think we don't know if they are difficulties or not. We're not trained in our field, since we don't know anything. Just tell me about the environment. Tell me how the feeding occurs in your house. And from there, it's like, okay, so you mentioned this, so does that, and then from there you keep on growing. So that ethnographic interview, which is just open the questions, conversation goes, of course, with time, but it gives you so much information that it helps really create patient-centered goals in the future and a great plan of care that will keep people motivated but also successful.
Yes. Okay, so one of my favorite questions to get to know the caregivers, and I try to align my questions according to those four domains. For the nutrition piece is tell me where you grocery shop. Where do you get your groceries? Who does the grocery shopping? Do you take tiny human A, B, and maybe C and D with you when you go to grocery shop? Because let me tell you, the more tiny humans you take with you to go grocery shopping, the more chaotic it gets, especially at the checkout aisle because they put all of that brilliant things. Yes. But that's a great way to ask a question without hopefully placing shame or negativity. Because if they do have, I've had families acknowledge, oh, Waffle, no, thank you, not on the couch. I've had families acknowledge that they have to go to the food bank, or my husband or my partner goes to the food bank. And those are raw moments where they might have embarrassment. And and we're supposed to do no harm.
And there's moments there, that's where you also learn. I've had a lot of clients there. They parents work at a restaurant, so they take home a lot of food that's left over for the rest of the people. They don't buy a lot out because of not having the enough income to bring so many things to the home, but they still bring some rich food because it will, or not rich, like I think I don't remember who gave me this example. I don't know if it ended up happening in a conversation between you and I or another one. So it did happen when someone was listening to who else to you and just let me know I will never forget it. But it was like having that example of if you eat an apple every day for a few months from now on, is it gonna be safe? It's an apple. And people will say, well, it's a fruit, but is it, if that's the only thing you eat from now on, it's not what we consider healthier. It doesn't really treat as well, might. So it's the same as now give me a chocolate. If you eat the chocolate only for the same amount of time, it's gonna do the same thing. And we have these two very big things that people say, well, one's good for your, it's a fruit, and the other one is a candy. So no, but at the end of the day, we want them to enjoy their meal tool. We want them to get food in their system. We want them to accept meal. And at the same time, for me, and that thing at the legal so cheesy wishes are very limited. For ranch, that's the win. They have more things. I'm pissed.
Also, those are such that's something huge. The flavor taste differences between zesty Cool Ranch and cheese Doritos. It's like opposite ends of the spectrum. And now you can branch out into I start thinking of the ranch flavor pea pods, the green pea steps. Not that those are some of my favorite things.
Like different flavors and then the extra veggie. It's like a lot. We have the crunchy, but we expand. So there's so many ways to go. But when you know what they're buying, when you know what they're bringing without shame, it's kind of like when they bring food and they're like, I'm so sorry I brought McDonald's today. And I'm like, why are you sorry? Like, and we start talking, how many times? Don't you like it? Oh my God, love the soda from McDonald's. So I do go every week. And I'm like, then that's part of your routine. So that's great. You brought it. Why not?
Yes. And it's so amazing to me how much we as humans can grow in our 20s. Because how I was raised, a child of divorced parents, but they had remarried. It was two very different homes in different parts of the state. And then, to go from that to college and, I was in an unhealthy relationship, but I saw how that impacted my food intake. But all of those personal lived experiences of myself and bringing that to the proverbial table. And if we open ourselves to the possibility of learning about different cultures, different beliefs, different approaches to meal times, to feelings towards medicine, and not just seeing the doctors and the specialists, but like how other cultures view the act of healing. And medicine can be your food, medicine can be your tea. I wholeheartedly think turmeric tea helps when I'm feeling puffy and bloated because one hysterectomy, but they left the ovaries. I like my turmeric tea, right? What? That to me, those are the lives that we tend to shape wearing faculty hat and clinical supervisor hat and CS hat or CF supervisor hat, right? Those, because that's typically that moment. But
And our outcomes aren't Saturnian biological skills we have at clinicians. It's more based on what's around the child's world. Like, so yes.
so if you could mentor the new incoming cohort of PFD practicums, what barriers or pitfalls would you tell them to look out for and be weary of?
Ooh,
The big,
and this is a personal question because I think that one of, families do face a lot of barriers. So I'm not going to be able to name them right now because then we're going to have a weekend podcast where we're just going to be morning the whole day and having meals together and everything. But, sometimes we need the big barrier of do they live in a rural? And I don't love how that word sounds, but yeah, when I say it, but it's lovely. And it's like, it's an R, I should lock it. But yeah, what underserved areas where there's really not a lot of eating specialists nearby. I saw it where I was here in Arizona in Mesa, and there's more specialists than I ever imagined around, very close, like very different from the island where, you can at 30-minute, people are like, oh, you're going to drive 30 minutes. Yeah, that's next door. Like, and I was used to 5-minute drives, 10-minute drives. So seeing that parents were coming from very far away because maybe I was the only feeding specialist that spoke Spanish, for example. So thinking of the geography, but also thinking of the systemic barriers that we have, which is maybe lack of providers that can match with what they're looking for. I was having this conversation this week with one of the new cohort in our class, which is they were like, oh, but how can I become a bilingual SLP? And she was monolingual. And I'm like, well, if you want to consider because of the definition bilingual where we're gonna have to speak another language, but I'm like, I've met so many monolingual SLPs, if you want to separate it between bilingual and monolingual, that do such great work because they're so culturally responsive that they do even better than the bilingual SLP. So I don't even see it as bilingual and monolingual. I see it as culturally responsive providers that can match what the family is looking for, or they open up. So that's a very big barrier. And I think that's a very big thing to consider if you're a new cohort going into the field of PhD, which is we may not speak their language, but you know what we can do with them, which is let's try finding an interpreter to work in them if you will speak their language. Let's ask those questions to understand that they were talking about, to understand where they're coming from, where traditions are. Even if you have to Google 5 minutes before going into the room, because I say, we train SLPs within the academia level, and we saw when we were students, we have to like this. Oh, speech language cohorts do so much. It's so varied, but we're learning so many things that it's okay to sometimes not understand maybe a syndrome or, oh my God, I think I heard that in my class with X professor. It's okay to Google it, but also be mindful of the resources that we find on. So I think the big barrier is the geography, systemic barrier, and Another big one could, or I'm going to say two more, maybe like the financial one. We always, and I collaborating with Dr. Amy Delaney and we did session and outside this year. So we're going to be talking about standardizing the clinical swallow EDA. And why that conversation happened, because we were thinking out, okay, we always talk about the gold standard. We have the instrument. That's a gold standard. I'm not saying it's not. I'm saying it is. But we cannot recommend the gold standard for everyone. One, not everyone can pay for it. And two, maybe we recommend it and they never go. We're schools English pathologists that can still diagnose PFD with SPADA. So we need to know what we're doing. So it's not like, oh, let me put you on hold after my eval until you get an instrumental done so I can confirm to you if you have this or you have that. So you may have insurance coverage when we do that. So we still have to be experts in our field and understanding how we do that whole comprehensive assessment, because it falls into the final one that maybe I could put them in the logistical. That goes with the geography, the transportation. Maybe instead of writing they're not compliant or missing that they did a no-show, understand the why. Are they having inflexible work schedules? Do they have childcare for other siblings? Do they have the challenges that maybe you recommended 3 times a week and they can only come once, people who only have certain amount per gas? Why haven't we considered a hybrid model? Are we open for that into doing that? Or can we then negotiate with them that's a longer extension that they would go home? And that's okay, because you still wrote the recommendation, but that's not set in stone. You can still talk to them. So the child care, the transportation, maybe when they bring the 5 siblings from the house, and I'm being very exaggerated, but even one sibling is enough to just do everything in the session and not let the one where our client drive, we can first of all that push note. Well, there's a lot of that goes into it, and that stinks. So all of these go together. So how do we go into like understanding, and it all falls into the caregiver worry, the caregiver stress. Are we helping them? I know we're not the mental health expert, but are we supporting into trying to remove that, or are we adding more pressure?
Yes. I wish I could go back and talk to early career me, right?
Me too.
Because and folks that are listening, learn from your mistakes, embrace your mistakes. Good Lord, we all cock up on like a royal level over the course of our careers, but it's the act of giving oneself grace and learning from, right? So I think back to when I first started doing early intervention and got into pediatric dysphagia, naively thinking it was the same as adult dysphagia, just small. So that chalk that up to number one. But when I moved to South Carolina, it was the first time I worked with interpreters. And I'm a I speak English and bad English. And bless Chad, he does a lot of edits on here to erase some of my fun 4-letter vocabulary bubble. So that's why I said leave him in the whatnot. But I had never worked with an interpreter before. And that is a learning curve. Miss Isabella, she was the first person to honestly sit me down and explain there's differences in types of Spanish that are spoken, which on this side looks like a dumb moment that I had no idea. She was the person who trained me and prepped me for working in a home where they spoke Tagalog and how to. He was like, Michelle, make sure you take your shoes off before you go in the house. Make sure you bring clean socks. But like it was done with so much love, right? And that to me, I feel like is a huge barrier is, are we trained in how to work with interpreters? Where can we go for that training? And where can we learn? And I had Inez. Do you know Inez? I know.
Forward with her then cutting cockpit. She's great. We're presenting together at ASHA. If you
Congratulations. She came on a year or two ago and talked about working with interpreters and like the prep work that you do before you even with the interpreter before you even go into the session. And I wish I had known those things, but that's
and that's what another great thing. And It's funny we're talking about that because 2 days ago we did as part of our multicultural class the interpreter training. So we have Dr. Salas Provence bring to the classroom, and she does have a company for that, but it's more because she's passionate. She's a speech language pathologist. She has done so many things in the field. We're lucky to even have her here, but our students learned with different scenarios, and maybe scenarios are medical or with SLPs that we model to them the DIE process. So we don't necessarily need to know the language, but we should greet the interpreter beforehand. We should work through. We have the interpreter. That's the B part, the interpreting experience, and then the debriefing. Why? If you're using an interpreter, let's say during a standardized assessment, we need to let them know that they cannot give any cues, any pointing. That if it's a client who has, let's say, trouble finding words, I need to know if they're doing a repetition. So that part of the talking with the interpreter beforehand is very important. And it gives the interpreter an idea of, do I have to act a little bit things out where I'm interpreting because I don't know how to explain it or different things. So when I went to the Philippines this past March to little Dr. Salas Provence, Dr. Centeno Vasquez, and 2 of our students, we went to the Protoflac when they were offering free cleft and lip palate surgeries to kids. So we were very cool to be part of the SLP as part of the team. So we were working on it. And we might mainly be, for one thing, which is, let's work on a lot of the times that Dr. Salas Provence has done in the past, like with most now working on increasing their intelligibility. But what we noticed, that was our first time that Dr. Centeno and I go, we're also very passionate about PFD and the skinny there. There's no way we're not going to be able to not bend it. So we had having this conversation, and we had interpreters because they spoke. It wasn't even Tagalog, it was a dialect. So we had an interpreter, we had to train them. And here I am, not understanding for the first time ever nothing that's going on because I'm used to working with Spanish speaking clients and saying words that don't mean the same to them and laughing during our sessions because I said something that meant something horrible in them. So I do speak Spanish, but I'm from Puerto Rico. So mind you, I won't say anything. If something you hear means something different, just please correct me. I don't mean it in the worst way. So they already start laughing with me because they're like, that means this. And I'm like, oh my God, I turned red. I'm like, why did I use that word? Well, I've learned so many things, but in the interpreter, when I noticed they were adding things when I just am in, presenting myself, and they're like, oh, this is Dr. Ivonne, that's the only thing I understood. And blah, 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 blah. And then they haven't cataloged a lot of words that are similar to Spanish. So I'm like, wait, I know that word. That's not what I said. Wait, what are you doing? And when I talk to them, they're like, well, I was doing that short introduction that you already did have. So we were like speeding things up. And I'm like, no, I don't want to speed things up. And they were completely open with it. So we have that back and forth way of just learning how to manage it because I thought I knew, but living it with another language that I didn't speak was very interesting.
Yes. Yeah. Yes. Also, I sometimes struggle with modern day slang. So
Oh,
even
yeah.
I said FUPA one time when I meant FOMO. So like that. Oh no, and moving could two ways. But like that's a problem. FUPA and FOMO are two very, very different things. So like words are tricky. But one of the other barriers that I had encountered and this is a new one, but I saw precursors of it back in South Carolina, right? But the gravity of it is newer. Not just food scarcity and access of food, which in and of itself is a huge issue, but also now the inherent fear of seeking help out. Because if we go to seek out help, will ICE come pick you up? Which is a legitimate concern. That is a valid concern. If you go to your WIC appointments, this is where I start worrying about children who have to go to WIC. They would have, and you have to get like weighed and, they check their iron. But what happens if agents are there or outside? And honestly, we can say, even if you are here legally, that doesn't mean that you won't be taken away. And if you have a child that has a pediatric feeding disorder, and if they are reliant upon a formula that is outside of their price point and they need this formula, these are these are barriers that pre-existed 6 months ago. What month is it? It's September when this is coming out. These barriers were there 9 months ago, but 9 months into the current administration, it can be terrifying. And so I'm going to put the onus on us as therapists that we need to know the resources that are available, such as, and not limited to, findhelp.org, such as, and not limited to, dysphagia outreach projects, such as, and not limited to, contacting suppliers of the formulas, of the bottles themselves directly, because as a therapist, lots of places will send them directly to you, like Dr. Brown's bottles, or Simply Thick, or with Savories, or, oh, the infant. I can see Lindsay. She lives in Arizona. She lectures for Gel Mix and Pure Thick. I mean, those resources are right there and they will get them directly to you. But are we doing our part to keep the whole family unit safe? And do we even recognize that as a barrier, or are we blinded by our own bias?
And giving them the resources, but also knowing that sometimes even as a fees, we can just reach out to the companies and have, let's say, some samples wherever you work. And that or you in the process that you have. Because here I'm assuming, utopia and how I try teaching, telling my students is like, let's say now we're talking about the treatment component. Now you have enough rapport, you have enough, you've worked so well with the client that you know when they're really scared. So you now know how you can reduce that barrier with the whole thing happening in mediation, which is we're not even that's a whole other weekend of conversation, but reducing some possibility of negative experiences that they could that maybe you can every time you visit them be the one who stops maybe giving praise for mile. Not always, you don't have to, but okay, I'll just I know what you need. It's on my way to your house. If I'm doing home health, I'll just bring it to you and they don't have to pull out. Or just taking some samples. Like, we don't always have to go the extra mile, but I like when we go the extra mile. It changes.
Called kindness and being a good human.
You can't teach empathy skills, but at the same time, you can be very aware of what needs to be, what your growth as humans can be. And I think that, it's maybe you're also not able to buy things, but you don't have to buy things if you reach out to the specific places. You just can pick the same thing for the same family that's free, that looks free for them. So there's so much we can do with kindness. And in my it was huge because even the social determinants of health, I do see them on the island and everything, but this diversity situation in Puerto Rico, we are also different. Like, if you see a family picture of all of us, the cousins together, you don't understand what happened there. Like, there's different colors, different hair types. There's all of the different things that were like, are we even related? So for me, when I started working out here, that's when I started seeing like, oh, well, wait, this is a whole other thing. Like, wow, microaggression.
Content Georgia, honey, of all.
Imagine that. Where people were like, oh my God, but you're Puerto Rican. And I'm like, you don't look like it. And I'm like, oh, like, how am I supposed to look like rice and beans? Like, what is it? Like, what's the Puerto Rican thing of it? Like, I don't get it. So knowing to the family, and you know what? That fear is very big. Like, even my dad called me and he was like, when that was happening, he's like, do you have your passport on hand? Always go with your passport. And I'm like we're U.S. citizens. And he's like, it doesn't matter. We don't look like U.S. citizens. We don't talk like U.S. citizens. So you never know what can happen. So it's that here, and I do understand that it's been happening before. Because while there's the fear of being taken completely and all of that, but before there were still the fear of being found. And not only the fear of being found and taken, but the fear of, is your child, when they weight them a little lower because we couldn't get formula, are you abusing them? Calling protective services. So there's so many things, and it could be just, there's so much things to unravel.
Yes. So, well, Folks, this is not to be doom and gloom. Please know that we are not here to be doom and gloom, right? But these are real barriers that are directly correlated in and of themselves to social determinants of health. These are factors that our families face every day. And the more we educate about ourselves, about the walk of another human, the better we are able to serve our families because we can set them up for success. If we take this back to science, to that Maslow scale of hierarchical need, if our family is at the base of that triangle, and one of my favorite Bible verses, and it came up this week in our Bible study, build your it's essentially build your house on a foundation of stone and not sand so that it doesn't slip. As I always say, my Jesus loves everybody. Even if you don't love Jesus, still love you because that's what my faith dictates. And that is a bias that I'm bringing to my work and my world is that I do my actions through that lens, right? And that's part of my cultural belief. But that ties into the next chapter of our conversation. Are we acknowledging another individual's cultural beliefs? Because where my Jesus looks like this, I don't have my children enrolled in Bible study as an elective at their public school, which is a whole other conversation because I don't know if that Jesus looked like my Jesus. Also, it's just Christian. There's not any other offering but like que sera. Take it away, lady.
So, wow. So considering yes, so and to close out also which goes into here, it's that so I'm gonna start with this to connect it with culture. It's that I think a pet peeve of mine is seeing the word or the term in notes that says the client was non-compliant. For me, I take it as a challenge. When I see non-compliance, I'm like, mm-mm. Or when I was working somewhere, they're like, they didn't want to work with OT or PT or to the other speech therapist like there. And I'm like, okay, good luck. I will get, we will work and you're going to see why, because it's not often the refusal. It's that the plan maybe just doesn't fit the family or their reality. And that's something we have to consider, that we need to adjust their therapy to their contracts and follow through if it improves. So, and it leads to the culture component. Eating is deeply, deeply cultural. Well, it shapes everything. It shapes everything from routines. You will be part of the family that eats all together sitting down. You may be all the household that just sits individually because we're always doing things. Like, it drives my wife crazy, but I prefer eating standing up. And she said, can you sit for a second? And when I said that, I'm like, I can't because I have so many things to do. That's something when I sit down, she's like, are you okay? And it's not that we don't have moments where we sit down, but in the day-to-day reality, I'm like doing so many things that it became a national. So are we being flexible with the routines we're recommending? Or are we being open to letting them know, like, I love that. I was looking on social media and Instagram, and I sometimes go to all those videos for the comments. I just love them. I should open a popcorn because some people are like, no, but how do you do? And it's like, it's the whole conversation of, okay, screens are not good, but are they the best for that client to increase that feeding behavior? So we have to see people individuals. Culture will change the food choices and those traditions. I cannot recommend an ITSE level that I'm not considering as diet modification or explanation. They use spices. They use different cooking methods. Are you going to talk about the different ITSE levels that go on social media? No.
No, Jackie Rodriguez. Have you seen her page? I love Jackie Rodriguez's page because she does ITSE levels, but then pulls them into like of her family and her culture, and I love that. Yeah.
Yeah, I was going to mention you first, but she got too excited. But he does it, and I bet she's going to repost them again when it's Hispanic Heritage Month. But knowing that makes a difference, like, because cooking methods just differ across cultures. I cannot put ice on everything because some people like it warm or temperatures. It also culture is rooted into the feeding tools that you recommend, the utensils. Are they using chopsticks? Are they finger food? Are they using hand feeding? So we have to adapt and not impose. No, you have to use a spoon because this is what the milestones say. No, we have to adapt. It's good to stop, we have to see the whole picture of it, Is it functional? Is it not? Like, is it something that we're just following some milestones that are specific to a specific population? Or are we, just imposing our biases too? We have to consider that culture will go with that belief that we were joking a little bit about the growth. What are the nutritional goals? Because some cultures prioritize that nutrition. Every time I visit my great grandma and my grandmother at this point is at that stage within her Alzheimer's into you look fat. Oh. And I'm like, I love you. That's beautiful. And then one day she randomly says, you look thin. And I feel that that's the day I look the fattest. But I love it because it's part of the culture because sometimes we want to be perfect. And there are families that work into don't eat that because you're going to get bigger or you got bigger, put them on a diet. So that belief of growth is very big in families that are from different places. So it doesn't matter the size, but maybe some people do matter the size, and that changes the way you're telling them to eat things that are preservatives, maybe instead of healthy. So you have to consider all of that. So are very important because therapy works when we adapt to those routines instead of replacing them. And culture leads to possibly language. Language, yeah, tell me.
When you talk about like the weight in the culture around food and weight, we have to add in that our height, weight, BMI norms are predicated exclusively off of white children.
Oh,
It's
yeah.
like that. And so you can't technically use those growth charts to say yay, nay, or indifferent because there's inherent bias in the formation of those tools. And that does not take into account individuals from different ethnicities and and their the inherent body image embedded with it.
And and the milestones. The milestones are based on white middle class children. So those eating milestones also are good to have as a guide, but we have to consider them. In the Philippines, all of them finger foods. And there was a bottle. And I was dying because a 3-year-old with a bottle, but at that point, wine also that was what they just had. And they just Peter it. And it does they were great doing everything. They still could finger food. They still could eat all the solids and all everything. Well, we consider them children in the future, but I'm not gonna die because of that. Like we're not. It's a joke. We're not the speech police. So we use the whole functional and what's not, or what functional, but what's also really impacting the quality of life of our clients. And if we think of that language, which is a very big part of that, we see that in the literature, it does mention that when interpreters are used, some caregivers felt better, but even with the interpreters, there's still that we still see sometimes in the literature that the interpreters, the caregivers still feel worried. Feeding therapy involves complex instruction, complex equipment sometimes, hugely emotional conversations. And we have to consider that whether we use an interpreter, our body language says so much. One of the times, even if we have an interpreter, modeling, incorporating people, the caregivers and the family members in your session. Like I joked and I mentioned, like, you're going to see in settings where they tell you you can't take the parents to your room. And I'm like, you question those places. Why? I always invite everyone to my room when I was doing therapy. Why? Why would I hide it? Pay for a session. I was supposed to model them. They're just with me 30 minutes or 5 minutes, 2 times a week or 1 time a week. Why can't they see what I'm doing? Is that are you thinking that they cannot go in because we're doing something that could be ethical component of it? So having them, even if there's a language barrier, see you how you are loving their child.
Yes.
they see the love and the care you show. They see the tricks and the tips and those things that you do that they can start implementing in the sessions. We also have parents who have been misdiagnosed or not misdiagnosed. They've been diagnosed, but then they use, I had one and that was a leaky mom, but that can happen. And I tell that story to everyone because you never know. That mom came from working with another SLP, but she never told me she already had services. It was not put in any documentation. I did my full eval. Diagnosis at the end of the day was very similar, but the main problem with the mom was the type of treatment that was being offered to her. It was going through negative behaviors, the negative reinforcement, force feeding. So when she came, that I gave her the diagnosis, and I'm here talking about how therapy would look like with me and how I take it slow. And because I saw the child also, how we work on building trust first, it could take 1 week. So, and the mom started crying, and I was like, oh my God, what did I say? And then mom opened up and said, she was able to even work with you, just getting to know you without, even being forced. And you saying that, it's just some music to my ears. And then she told me, and I'm like, oh no, 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 I don't work that way. For a child to even accept a food, I'm already writing in my notes. If they were able to carry their lunch box or walk into their room, that's acceptance. They can be in the same room with me. If they can sit in a table with me, that's acceptance. That's growth. If they can put the lunchbox instead of mom holding it in the table, that's growth. That's truth. That's obedience. Well, that language component doesn't have to be because of speaking a different language. It's more of you offer the resources that you have. But also, there's always those translations that just don't transfer well. You can't translate everything the perfect way you want it, but you have to feel that you have to notice if they're going to be feeling left out. So I always push for that and to, be that change that we need in the world because they keep saying like, well, wasn't but only then creating the resources. So whenever possible, we need to create those resources that reflect the culture. Just like what Jackie is doing, which is she's doing the influence for specific,
Yes.
places. I once worked with a family whose meals, the traditional meals, included very spicy meals and also a lot of texture. In order of eliminating that, we just worked on I worked on getting to know the meals more and how can we adjust funny in the textures, but maybe still keep the spice for, I think it worked that way, but also the child didn't want that spiciness. So it was, how do they feel that we can still add the spice that they want to add? Because turmeric is added in food, or like there's some spices that for families, that's what they need and you have to add them. So how can we still have that, but not any too much like they're adults, they can tolerate and see, so they can enjoy the meal with discomfort. Or I learned about wine and we started dipping things in it because it was like something that was sweet and I keep forgetting the name. It was from the Mexican culture. And once mom brought it, because I was like, have you ever attempted ketchup or things like for dipping? When she, oh, I'm going to bring something and she brought it, the child dipped everything on it. It's fruits. He started even the things that you're like, why are you dipping, let's say a chicken tender in an applesauce? Why not? Why not? So, why?
I had a family one time and they brought McDonald's, which I was totally chill with. But mom was like, I really want her to eat sweet and sour sauce. And I was like, I'm sorry, why? And just genuinely like confused why you wanted the child to eat the McDonald's sweet and sour sauce. And mom explained, I have 4 or 5 other children in the van. We're going through the drive-through. Everybody else went sweet and sour sauce except for her. Typically, that one gets missed, and then it's like a complete meltdown. So she wanted the child to learn to eat McDonald's sweet and sour sauce for her headspace to make family life in the van on the way to their bajillion after-school activities go smoother. And you know what? That was important to them as a family. Also, I will eat a lot of things and really don't like sweet and sour sauce. But whatever my families bring, with the exception of meat, like I will break bread. We're going to figure this out together.
The name of that I didn't remember. It's chamoy. It's called chamoy. It's sweet. It's probably tangy, some sort of spice. They use it a lot with fruits and snacks. But he was eating everything with chamoy. Once I put like a dipping tape, this thing, I was talking to mom and he started eating on his own. And mom was over there crying in the corner because he was just doing it on his own, dipping everything. And she's like, I'm gonna have to buy chamoy in bulk. Like wheat of dipping it into every plate. It's like, you know, there are things I don't eat also, like you just mentioned, when they bring vegetables, oh God. I think this is the moment that I still prepare. We work through it and I'm like, parents, let's involve let's work all together. And I'd noticed also that the parents lead that education into, they always feel that they need to say they want to start with vegetables and fruits because they feel that that's what everyone expects. And when I tell, no, I'm going to start with what they're already eating and showing something that works. Like if they eat Doritos that are cheesy, I'm going to possibly bring Cheez-Its that are cheesy or something similar and start growing from that and they're like, oh, and because I sometimes ask the question, but what type of vegetables do you eat at home? Oh, we don't eat vegetables. Or what you like? Like what? And or SO or I've heard of students that sometimes tell me, oh, because we all learn. Like I still learn about past me. I still don't like how I wrote different things in the past because I've improved and we evolve and we are a growing, you know, clinician. So I heard of a student who said I was working I saw that we were working with strawberries and the child was, being okay with it, but never put it in their mouth and because that's what we had in the clinic. So when they started a conversation with the parents said, no, we never buy fruit. So no one eats strawberries at the house. So then what are we doing? And that's, so we have to consider so many aspects of it into all our treatment and push for that and think of the culture. If for that, the chamoy for that client was the best, bring what it is. I tell them, bring what you have for your pantry. Don't go to the supermarket. I want what you have in your pantry. If not, write me a list of things you usually have. And if you don't have it, I'll find something similar or bring that.
Yes. So one thought that one lived experience that was new for me. My best friend growing up, Michelle Dudash. I'll never forget. She's Catholic, and they would have High Holy Week, and they would only eat fish, and they would abstain from meats. Well, I mean, it's corresponds to Lent, but I grew up Southern Baptist, and now we go to a Episcopalian church, so huge differences. But the religious changes in foods over the course of a calendar year, where some faiths abstain from eating during the day, or some faiths avoid certain foods because of the holiday. And how do we support our caregivers while recognizing the child has a pediatric feeding disorder and supporting them during those times? Those are things that I still feel like I myself need to grow in, but it's on a truly case by case basis because not everybody is as strict in their faith as another person, right? But what are your thoughts there or your recommendations there?
No, it just involved everything. I think that whoever's listening to us may seem or may feel, I hope not, but there's so much repetition of what we're saying over and over. And maybe that there's so many things that are the same, or, why are they talking about this? Is common sense. Well, people, common sense is common in the world. So I think that the best way to do therapy, the best way to do assessment is to just honor everything, honor the client, honor the culture, honor the language, honor the emotion. And for ourselves as clinician, we also cannot forget that we have to advocate for our own selves when we're doing our own things and grow as clinicians. It's an ever evolving field. I learned this from Dr. Centeno Vasquez, and she says that when you feel that you know it all, that's your moment to retire. Leave the field because no one ever knows it all. You have to keep learning. Every year there's something new. every year there's a lot. Like, it's not like this is a new thing, social determinants of health and everything, but it's now something that we're looking into. In the past, where cultural responsiveness is not new. It's just that we're going into it again. Like, we are now seeing it more. There's more things in the field. So I don't know if that even asked that question, because I think I blacked out and did not. So if not,
No, no, but it did because we can only know our life and our faith. There's no possible way for us. I'm glad that we've gone from cultural competence to cultural sensitivity and cultural humility, because it's impossible to become culturally competent. And
we have our things that push us. We have our own possible thoughts. But what we tell the client, it may be aligned with our own views, or it may be the opposite. And we have to work. We don't do the official oath, but we do take sort of an oath to follow. And we have an ethics code of conduct. We have a scope of practice, and we're not going to stop treating someone necessarily, because they just use their, assurance one or another thing. If it does to an issue, you can definitely just refer and move forward, but we have to consider so many things. Like, one time a student said, but I can't do oral hygiene. Like, what about those mouths? If I'm working in a hospital, like, halt, and they're like, I'm going to skip them. And I'm like, if you're the only FLP in the hospital and they're there, you're just going to skip that because you're not feeling well. So you can then call the CNA, call the nurse, work together, educate. So you still do your part. You still do your work. We cannot stop doing things because, there are moments where I talk to patients, and I never am married to a woman, and they ask me about my husbands. And there are other clients that I'm like, oh yeah, they tell me, how's your husband? I'm like, oh, my wife is for two dogs. And there are others that I'm like, I'm not even gonna go there because it doesn't make a difference in their future. It's like, if the sport is how they feel like it, then that's okay. Like, I can't think. There are moments that, yeah, so I'm not saying do not work on your mental health with your clients, or could, keep quiet on many things. There are moments where we can say things, but there are, do we mean it in the meanest way, or is it a real microaggression, or was it not? I've had kids, I have a necklace that says amor. It means love, right? So I had a child who, in front of the students, came. She was like our mock patient, and she was like, oh, no, we were talking with her, and she says, oh my God, what does that say? And I'm like, well, it says amor. And she said, and I'm like, that means love. And she's like, oh, your voice, they've been thinking so much. And I'm like, he does. But some of the students were like, and then when they left, they're like, why didn't you say? I'm like, what do I get from saying anything right now? Like, yes, the mom came to me. We had a great conversation. I'm like, I never took it out of disrespect. We were talking she was a student. I was even joking with that. But what's something that even your mom said? It's like, we encourage everything, but the child has not seen that much. She doesn't necessarily, it's surrounding different types of families where we have two men, two women with children. But when they do see it, I know they're not going to forget into saying, like, when there's a question into look, mommy, yeah, that's a family, because it's going to sink into those. So there's some different moments. So it's, is it the parent? Is it the child? Like, I'm here for the child.
yeah, I have a family that I've worked with, and the family has Ehlers-Danlos syndrome, and which has been a increase in my area at a very unique pattern. And I now have on my caseload 4 children with the exact same PFD profile, exact same medical signs and symptoms. And I'm kind of curious why this increased prevalence of this sign and symptom now and in this location. It just seems it's an outlier of a variable, right? And so I'm kind of curious about that. So my scientific brain goes down this way, but my heart brain goes the first family that I learned about these signs and symptoms of connective tissue issues has two mommies and they're Wiccan. So, and with a family with ARFID. And so learning about their faith, their because it is a faith, and learning about the culture around that embedded in it's a two mommy family. Like that was and they were hesitant to work with me because I'm a Christian and I totally understand. And I'm like, oh honey, there is no judgment from me, but like you do you. And it was a huge learning experience for me, but I am called to serve those that need the skills that I have.
Only took an oath.
Yes, I did. And I love what I do, and I love humans. So,
Because we're embracing cultures, we're embracing our client, but that's will change. It doesn't have to change when you go back home. You don't have to change. You may grow because we learn so much from our families from a different culture level.
yes.
Well, and being culturally responsive is not only about the color of our skin or the language that we speak. That's just the tip of the iceberg. There's so much more under the water. That's for always. There's every SLP will all at least one time work with one culturally linguistic diverse client. And then be client. And some of the students are like, well, but they're white. No, people who identify as white can still be diverse, can still be different from you because they're from a different religion, they're from a different, they have different traditions. You cannot assume that because they say they're white, they're going to sit at a table with all family, they're going to read to their children for literacy, they're going to do this, that's not the thing that goes on. Everyone is different, and it doesn't matter the color of your skin and the language you speak, you just need to get to know the plants. There could be a point where you're working with something that really has been an advocate for things hugely that won't really follow with what you do, or the comments in therapy don't align for it. You can still have a respectful conversation about how you feel and how those comments in the session affect you. And if they continue, you can stop the services and just mentor an attempt at it. Like it doesn't want me working with the child, but as having you with doing those things, and just it's not something like in a workbook. So you can definitely nice or something. But I always say you can also educate and be respectful. With an open and adult conversation into different things. I know COVID happened. I had parents who didn't want to wear their mask because they didn't believe in the vaccine. They don't believe in COVID. Well, I had a parent that I kept seeing. He loved working with me because they were doing so much progress, but he always kept fighting with the front desk because he didn't want the mask. So when he was walking into my room, he sometimes took it down. So I was like, sir, remember, there is a strict policy in this clinic to wear it. We're in the room. As I turn around, he takes the mask off. At this point, the clinic is very strict, like even telling us, like, if you can't breathe, go outside, take the mask off, like something, or close yourself in the room. So I'm like, sir, I know that the front desk told you. I did tell you, you were aware of the policy. And then he starts going into all these different things. And in my mind, I was like, I just know that I was like burning, but I was like very demure, very mindful. And I'm like, I am just passing on the information that comes from higher up. Look at this paper we have in the door that it says the policy. I never said I understand. I said, you have some concerns. I can send you to talk to the manager who's not here right now, but that's a conversation we may have. But at this moment, I'm going to start therapy. I need you to quit your mess. No, okay, that's not a problem. So I open the door and I'm like, we are going to cancel the session because we can't the rules. And then I will definitely
In kindergarten, by the way.
let the manager know why. We have very different thoughts about it. You know what happened? He never thought about taking off the mask because he was able to put his son first.
Good. Okay.
It went in a long conversation, and sometimes it doesn't go the correct goal. Sometimes they can, but we have to be open, understanding. I never said I understand. I never said I agree with you. I never acknowledged it. So I was completely in the opposite mind of thinking. So I'm like, I I know everyone has their own thoughts and their own beliefs. And, we are not going to go into what I think or what we both think. That's a very personal decision of this person who extend this thing. So we can cancel sessions, but we still have to be open into that we have that conversation to let them know how we felt before just kicking them out of the door. Because a lot of the times I have the skill set to very much support your child.
Yes. This has just been such a delightful hour with you.
I will be very nervous. I'm not gonna lie. Oh my God! Look, how we he's home. Don't you sound red? I shouldn't have learned that because I'm turning all red. But do this. So, and this is because I'm very passionate about this, and Dr. Santana Vasquez and I are working on some of the things we talked about, like what you were mentioning about having that for graduate students. We're working on things for clinicians that are not really existent at this point because we we cannot reach out to everyone. And it's easier that they could maybe do a Google search and as something pops up. And
Yes, this is okay. So, folks, when the first time that we met in person, I think I stole you from your bride and we spent like an hour and a half or 2 hours sitting at a bar. I mean, there was, if memory serves correct, whiskey sours.
Good been hitting. Mary was so confused and she's like, oh, you know each other? We're like, just met. And she's like, and we're like, well, then vibe. Like it just sounds natural. And I was so scared because I'm like, I don't want to be those people that are like, I look up to you and I'm like, hey, Mitch, I just follow you and just wanted to get your FP thing. And that's how I felt. But it was like, no, it opened up for collaboration, for a lot of conversation, the knowledge. And then I do remember you felt bad. And I'm like, where's your wife at? Because I'm going to take her something to drink while we keep talking just that she doesn't feel left.
Oh, this is great. Okay. I would love to do a follow-up podcast with you and the woman that you work with on interpreting. You said Santano?
Dr. Salas Proban, Marlene Salas Proban.
Yes, please.
She has been in the field for many, many years. She was one, part of the Hispanic caucus from the early beginnings. Now she's going to be part of the board of directors of ASHA. So she was great. So yes.
Yeah.
And she would love to talk about that interpreting.
Yes, because this is so needed. And with a full heart, thank you for leading with the complete conviction and compassion that you bring. Because that is to have leaders that stand their ground, but do so while giving grace that is an uncommon skill set. So thank you. Even waffles agree.
Allowing me, I do love talking about everything that's surrounding this topic. I feel very passionate about it because, it's not only that he is complex, but also social determinants of health, understanding them if you've never known about it. It's also complex, but it also is a very critical part of the complexity in science, PhD. So if we're and he more than we're just never addressing this whole problem, only less half of this. When we're advocates with educators, we have to partner with families, so we have to meet them where they are, not just in the clinical aspect of it, but socially and something we have emotionally.
Yes. Yes. Okay. So my final question for you is if somebody is listening and they are so moved, do you have an organization or an entity or a scholarship or whatever where folks could donate money?
Yes. Phasia Outreach Project. I think that Hillary Cooper has done amazing things, bringing that baby up and working towards it. If you want to donate, please donate there. They have supported so many families, and she is very hard worker. She is also going to talk about the impact of the Dysphagia Outreach Project at ASHA. I think she has a poster. I think it was even a poster that has one of those in Meredith's postal. So I think that, shout out to Hillary. I know how hard you've been working. So if anything, send to the Dysphagia Outreach Project. And if you still want to donate more, just donate to Feeding Matters too.
Yes, folks. Thank you for joining us on our journey. Wait, if somebody wants to reach out to you directly, what email address or social media handle, how can they reach you?
Okay, so my email is the longest email in the world. So it's, sometimes it's just easy to find AT University LLP, and I'm gonna be there. But if not, my Instagram handle is Ivonne underscore Marie with two E's at the end because everyone in Puerto Rico has the Marie's middle name. But in LinkedIn, I'm with my full name, so Ivonne Maldonado de la Rosa. And that's something that I think that when they publish the podcast, you can see my name on there. So that's how I'm there. And if you were to want to email, then it's my initial for my first name and the Maldonado de la Rosa at atsu.edu. But, once you see my name, just put it in Google and something will pop up. So don't worry. Be okay and send me your request to my Instagram if you want or LinkedIn. I'll just do that.
Yes. And I'm popping in and adding to all of the things. But thank you, thank you, thank you.
So much, Michelle. I hope we talk soon and see each other and, have wine.
Yes. Folks, if you have questions, be sure to reach out at First Bite Podcast. And it looks like we'll be seeing everybody at ASHA. So thank you so much.
Thank you.